Good morning. Warm welcome for the morning session today for your oral presentation. And to chair this session, I would like to invite Dr. Eleanor Amparado. She is a council member of APIS and she is presently working at the WOW Doctors Hospital, Philippines. Her area of interest are diabetes and thyroid. Madam, please take your chair. To accompany her, we have Professor Sara Mathai. She is a professor at CMC Vellore in India, and her area of interest are growth, thyroid, and bone. Madam, our first speaker for the day, she is Dr. Shruti Mondkar, and she's from India, and she would be presenting on adult height outcomes, validation of growth response, and adult height prediction models in Indian children with idiopathic growth hormone deficiency. Dr. Shruti, please.
Good morning, respected judges. My topic is adult height outcomes, validation of growth response, and adult height prediction models in Indian children with growth hormone deficiency. The aims of growth hormone therapy in GHD are to use an effective dose that promotes growth without causing adverse effects and treatment that is cost effective. However, the growth response and the responsiveness to growth hormone is variable, and that forms the basis for individualized approach to treatment. There are enormous expectations from children and their parents towards the effect of growth hormone on their final height. Hence, the accurate prediction of adult height within few years of GH treatment onset would be advantageous. Coming to the concept of growth response and responsiveness. So annualized height velocity is a measure of the response to growth hormone, whereas index of responsiveness is the degree of response to growth hormone. So that is similar to the concept of a Z-score. That is, it's the difference between the observed and the predicted height velocity divided by the standard deviation. So if there is a negative value, it indicates reduced growth response, positive value, better growth response in comparison to a reference cohort. And this serves as a guide for treatment optimization, that is increasing or reducing the dosage. A good initial response and responsiveness to growth hormone is likely to translate into better adult height outcomes. Professor Ranke et al. Developed a growth prediction model using the KIGS database. They found that the negative predictors of height velocity during first year of treatment were maximum stimulated growth hormone value, the age at onset of GH therapy, height minus MPH SDS, and the positive predictors were birth weight SDS, log of GH dose, and body weight SDS at onset of treatment. This is the research of our group on growth hormone deficiency in a nutshell. So we planned the study with the objectives of assessing the gain in height and adult height achieved following growth hormone therapy in Indian children with idiopathic GHD, either isolated or multiple pituitary hormone deficiency, and to predict adult height using Ranke et al.'s prediction models and to assess the relationship between achieved and predicted adult height. This was a retrospective observational study which included proven cases of GHD or MPHD who were prepubertal for at least 1 year before treatment, who had received GH for at least 4 years, and data on their adult height were available. Those with acquired GHD or on concomitant medications likely to interfere with growth hormone response were excluded. We calculated anthropometric Z-scores using the Indian reference data from 2019. And growth hormone deficiency was defined based on auxological parameters and peak stimulated growth hormone concentration less than 7 on 2 dynamic stimulation tests. These were the formulae used for calculation of various parameters. The predicted height velocity during the first year of treatment was calculated, from which the index of responsiveness was calculated, and further the near final adult height SDS and the final adult height. The mean age at starting treatment was 9.5 years, with a peak stimulated growth hormone value of 1.5 microgram per liter. The mean GH dose during the first year of treatment was 0.25 mg per kg per week. The mean height velocity during the first year of treatment was 10.7. The mean predicted height velocity was 10.5. The gender-wise differences are shown in graph 1. And the mean index of responsiveness was 0.08 SDS. There was a significant improvement in the height for age Z-scores as well as weight for age Z-scores at each stage. That is from onset to 1 year of starting treatment to stopping and adult and achieving adult height. And there was a gain in plus 2 SDS in the height for age Z scores. The BMI Z scores remained unchanged. The predicted adult height SDS was minus 1.1, while the attained adult height SDS was minus 1.7. So there was an overprediction of 0.6 SDS. The mean, it can be observed that all individuals achieved the adult height SDS within the reference norms for Indian normal population. And the difference between the predicted and attained adult height was 4.3 centimeters, which was larger for boys, 5.4 centimeters, and narrower for girls, 2.5 centimeters. There was a significant improvement in the difference between the height and MPH Z scores from minus 2.7 at the onset of treatment to minus 0.6 at adult height. A strong positive correlation was noted between the predicted and attained adult heights and SDS. Younger age at starting growth hormone treatment, more severe GHD as evidence from the peak stimulated GH response, taller parents, and more severe height deficit correlated with higher height velocity. An inverse correlation was seen with the weight for age Z scores at starting GH. This is an atypical finding which was contrary to Ranke et al.'s findings, who found a positive correlation. This could probably be because of the unique lean phenotype of Indian GHD cases, wherein studies have shown that more severe GHD is associated with a much lower weight for age Z score. So this could be an indirect measure of the severity of GH, and hence we got a negative correlation. Bland-Altman plots demonstrated that the mean difference between achieved and predicted adult height SDS was close to 0 but not equal to it. The height was predicted height was overestimated by 0.6 SDS in boys and 0.5 SDS in girls. There was an overprediction for shorter adult heights and an underprediction for taller adult heights in both genders. On comparison of those with GHD versus MPHD, the peak stimulated growth hormone levels as well as the height for age at onset were much lesser, but there was no difference in the final adult height SDS between the two. Thus, to conclude, GH therapy led to significant improvement in height in Indian children with GHD and MPHD. The mean adult height was within the normal range for Indian population. The prediction model accurately predicted adult height with a narrow difference of 4.3 centimeters. It overpredicted in those with shorter adult heights and underestimated in those with taller adult heights. And the predictors were similar to Ranke et al.'s growth prediction model, except inverse relation with weight for age. Utilizing the height velocity prediction model and IOR during first year of therapy, optimization of GH dose and individualized therapy is possible, particularly important in LMICs like India, where this could be an economic option without compromising on height outcomes. Thank you.
Thank you, Dr. Shruti. Any questions? Can I ask you a question?
Sure.
So does this prediction model predict different height velocities for the different years of treatment? Because
Yes.
we know
Yes.
what does it show?
So we've used it only for the first year response. We did not have enough data for heights at each year for the next 3 years. So usually there are height prediction equations for every year for the first 4 years. So we've done it only for the first year response. But the model does, the original model does say that the response is dependent on the previous year's height velocity as well as the GH dose.
So the predicted final height is based on 1 year's response in this in your study?
Yes.
Okay. And how long did you follow them up for?
Till the adult height was attained.
Till the adult height was attained.
I mean, we used retrospective data. The data was extracted.
Yes, sir.
Yeah, good study.
Thank you, sir.
Many of your patients must be in peripubertal age group because your mean age was 9. So just wanted to know whether you have used the sex steroid priming and this data combined with peripubertal versus prepubertal both.
Yes, sir. The data contains both. For those who were in the peripubertal age group, priming was done prior to growth hormone stimulation.
And your prediction model is separate for boys and girls, or it's a combined because some of them
It's
has
combined.
entered
The
puberty.
inclusion criteria were those that they have to be prepubertal for 1 year from the onset of treatment. They have to be prepubertal.
Because issue is if they have entered puberty,
Yeah.
girls get growth velocity higher
Yes,
in
those were
early
excluded,
part,
sir.
and the boys get later part.
Yes,
So
those cases were
combining is
excluded.
difficult.
Yeah, those were excluded.
Good.
Yeah. Thank you, sir.
Thank you very much for that
Thank you.
good discussion. Dr. Motkar, may I now call on Dr. Nupur Rani Agarwal to present a study on the role of serum metabolomics in diagnosis of growth hormone deficiency.
Good morning, everyone. Today I'm going to talk about the role of serum metabolomics and diagnosis of growth hormone deficiency. This study was carried in collaboration with Endocrine Department of AIIMS, New Delhi, and NDTL, and was funded by ICMR. As we know, perturbation in the growth hormone status leads to growth hormone deficiency and growth hormone excess, known as acromegaly in adults. But these two disease states present diagnostic challenges because of pulsatile release of growth hormone, and its secretion is also influenced by various factors. To mitigate these problems, we did serum metabolomics, which deals with the study of small molecules lesser than 1500 Dalton in biological fluids. So the objectives of the study were to investigate changes in metabolic fingerprinting associated with perturbed GH levels, to identify biomarkers and related metabolic pathways using LC-based metabolomic analysis, and to study how patients undergoing growth hormone replacement therapy affects body's metabolism, and identify potential biomarkers associated with different disease GH statuses. So coming to methodology, the sample group consisted of 40 subjects with confirmed GHD were compared with 40 age and sex match healthy children. Next group was growth hormone excess, that is acromegaly. 50 subjects were compared with 50 age and sex match healthy adults. To have a deeper understanding of how growth hormone replacement therapy affects body's metabolism, we did longitudinal metabolomic analysis, and for it blood samples were collected from 20 subjects who were on GHRT, that is at 0 month, that is before the start of therapy, 3 months after the start of therapy, and 6 months after the start of therapy. We also collected samples from 75 subjects who were on growth hormone replacement therapy for more than 6 months, and from 30 subjects who stopped GHRT more than a year ago. For analysis, high resolution Orbitrap mass spectrometer was used in full scan positive polarity mode, and to understand changes in metabolomic profile, multivariate statistical analysis, namely principal component analysis and principal least square discriminant analysis, was done using compound discoverer software from Thermo, and perturbed pathways were identified using MetaboAnalyst web tool. All the significantly differentiated peaks were annotated using HMDB. Now coming to metabolomic analysis between GHD and NCC group, PLASDA, which helps in identification of differential metabolites, was applied, and top 20 metabolites from this analysis is shown in heat map, and as can be seen clearly that the listed metabolites of the heat map shows perturbation in GHD as compared to NCC. Now these metabolites from PLASDA and top 20 metabolites from PLASDA was used to obtain PCA score plot, and we can see that clear separation between GHD and NCC group. And using all the metabolites, significantly perturbed metabolites from PLASDA analysis and t-test between GHD and NCC, we identified perturbed metabolic pathways in GHD subjects, and the most significant perturbation was observed in glycerophospholipid metabolism and D-amino acid metabolism. Now going to longitudinal metabolomic analysis, we did pairwise analysis between GHRT3, that is subjects who were receiving growth hormone replacement therapy from this up to 3 months, and GHD, GHRT6 and GHRT3, and GHRT6 and GHD, and we observed clear separation between all the groups in PCA score plots. Now, looking into the heat map between GHRT3 and GHD, we can see clearly that the level of metabolites is significantly perturbed in GHD and is reverting towards normal on application or on administration of GHRT. Further, we compared GHRT3 with GHRT6 and observed that the shift in the level of metabolites continued towards normal with continuation of therapy. And to get a clear picture of how GHRT is exerting its effect, we did metabolomic analysis between GHD and GHRT6, and as can be seen clearly in the heat map, that almost more than 5-fold change in the level of metabolites are observed in GHD patients as compared to GHRT6. Now, the perturbed pathways between GHD and GHRT3 were D-amino acid and pyruvate, and the most significant, and as the therapy continued, more number of metabolic pathways were observed to be deregulated in GHD compared to GHRT6, and the most significant one were glycerophospholipid, D-amino acid, lysine degradation, etc. Now, we also did metabolomic analysis between NCC and subjects who were receiving growth hormone replacement therapy for more than 6 months. And as we can see in the heat map, that the level of metabolic difference or fingerprinting is declining as the therapy is continuing for longer duration. Now, to have a clear image of how GHRT is exerting its effect, we also did metabolomic analysis between NCC group and GHRT of, that is, patient subjects who stopped GHRT more than an year ago, and we can see that after this discontinuation of therapy, the level of metabolites is shifting towards GHD, back to GHD. That is, the effects of GHRT is temporary and is reversible. Now, discontinuation of therapy also resulted in perturbation in larger number of metabolic pathways, including glycerophospholipid, taurine, and hypotaurine. And coming to metabolomic analysis between excess and NC, we can see almost 2 to 3-fold change in the level of metabolites in GHE compared to NCC. And the perturbed metabolic pathways in GHE are D-amino acid, pyruvate, seleno compound, etc. So, coming to the summary of the work done, now the significant perturbations were observed in individuals with GHD, and the GHRT was able to effectively mitigate metabolic changes associated with GHD. The effects of GHRT may be reversible as evidenced in the heat map, and the most perturbed pathways were associated with the maintenance of cell membrane structure, protein turnover, then energy metabolism and amino acid metabolism, and several phospholipids, sphingolipids like 1-palmitoyl glycerophosphocholine were found to be perturbed in GH level. But further studies with larger number of participants and different ethnic group is needed to assess the generalizability of identified markers and metabolic pathways. Thank you.
Thank you, doctor. Any questions? Yes, sir.
Thank you for that interesting study. I just had a question whether all your patients were isolated GHDs or combined pituitary hormone?
No, sir. We did from both the patient group.
Okay. Yeah. Because if you also had associated hypothyroidism, I wondered whether your metabolome will show a difference.
Yes, sir. Yeah, it means if I also did because of the time constraint, I just narrowed down my presentation. But if taking into account into other means varying factors also, then also we can see that the metabolites were showing perturbations, and they were able to differentiate between different groups also.
Okay, so different endocrinopathies.
Groups, and we were getting different set of metabolic profile which were altered in a particular group as compared to the previous one.
Okay, thank you.
Okay.
Yeah, no, congratulations for that paper. I had one question. I mean, this is a very good insight for all of us to understand what is happening. How can we apply it clinically based on these biomarkers? What do you think is the future holds for
that's
them?
a good question. That is, actually we have conducted untargeted metabolomic analysis. That is, we were not having any clue, and we were looking for the biomarkers that could help in the detection of GHD patients or GHE early markers. But since it was a pilot study and it needs further evaluation, and this was untargeted, further studies means considering into these metabolites, we need targeted metabolomics to be done. That is, we have to quantify and then we can apply it in the clinical data set.
And any growth hormone dosage effect in the response therapy? Did you find anything like that?
Sir, actually, we were not. I have not much focused on the level of the therapy. Means the subjects were given standard doses of therapy as per the age group or as per the condition. But we have not taken into like, okay, this dose is for this metabolic group. We'll consider the other. We will consider for the next metabolic group. We have not done that.
Thank you, Dr. Nupur. We'll move on to the next study. It will be presented by Dr. Ravindranath Reddy. Prediction of first-year growth velocity response to growth hormone therapy in patients with growth hormone deficiency.
Good morning all. This is Dr. Ravindranath Reddy, Senior Resident from All India Institute of Medical Sciences, and I'm here to present our study on prediction of first-year growth velocity response to growth hormone deficiency in growth hormone deficiency patients. So since the licensing of growth hormone therapy in 1980s, there has been varied spectrum of indications where growth hormone therapy has been used, and also the response to growth hormone therapy has been variable in both international and national studies. First, coming to some Indian studies which have seen on the growth hormone therapy response, we can see that nearly the first year height velocity ranged from as low as 8 to 8 centimeters per year to as high as 12 centimeters per year. Also, there has been multiple racial and ethnic differences across international and national studies. This study by Hawks et al. In 2021, which included 7,000 children across different ethnicities, has shown that those children with non-Hispanic blacks, they have very low peak growth hormone stimulated levels, and also their Z scores were very low, and also the difference with mid-parental height was high. So this in longitudinally has also shown that the response to treatment outcomes is also different across the nations. So the need for our study was to see this, the first year growth response to biosynthetic growth hormone, as it varies across different ethnicities, and the data on the predictors of first year growth velocity is very sparse from Indian subcontinent. So we aim to predict the first year growth response to growth hormone replacement therapy in both prepubertal and peripubertal children with growth hormone deficiency. It is a single center observational study, and we included all the children with growth hormone deficiency, and all the acquired causes of growth hormone deficiency has been excluded, and who discontinued growth hormone replacement therapy for more than 1 week were also excluded. The anthropometric investigations and the growth hormone replacement therapy were performed as per the standard treatment protocol, and SPSS 2021 was used for statistical analysis. Coming to the results, of the 257 children who has been treated with growth hormone replacement therapy, those with acquired causes and other causes of other conditions like idiopathic short stature and Turner syndrome were excluded from our study, and we included only 107 children with growth hormone deficiency. Of this, 77 were prepubertal and 30 were peripubertal. If we see the baseline characteristics, the mean age was nearly 11.36 centimeters with height SDS of minus 3.76 in the combined data. Next, coming to the subject categories, the peak clonidine and glucagon growth hormone peak was 2.75 nanogram per ml and 3.67 nanogram per ml. And if we see the results at the start of growth hormone treatment and first year post treatment, the height SDS has increased by 1 SD. So in prepubertal children, the height SD change was 1 SDS change, whereas in peripubertal it was 0.8 SDS, and also there was improvement in the bone age. So we saw that in prepubertal children, the high growth velocity during first year was 11.12 centimeter, and in peripubertal children the mean was 8.85 centimeters. So with this, we performed a multiple logistic regression analysis to see the variables with growth velocity at first year as a dependent variable and all other as the independent variables, and we found that age at baseline was inversely correlated with that, and difference between MPH SDS and height SDS was positively correlated in prepubertal children. Whereas in peripubertal children, gender was negatively inversely correlated, whereas difference between MPH SDS and height SDS and also mother height was positively correlated. Using this analysis, we have developed a prediction equations in both prepubertal and peripubertal children. Coming to comparison of these prediction models, so since the development of prediction model by Rankis et al. In 1999 using CABI International Growth Study Group, which included the children with growth hormone deficiency, interestingly, we can also see that although there were multiple other variables, there was also age in year at the baseline and also difference between height SDS and MPH SDS, which were inversely correlated with the growth velocity outcome. And also in our study, we can see both those two. And the 2001 by German study also shows that the difference between age and bone age was inversely correlated with the growth velocity during first year. And there are other prediction models which have seen for 24 months regarding the growth velocity. And so, although there are multiple prediction models developed worldwide, the use of these prediction models is very less till date, and majority of the institutions, they take as the peak growth hormone velocity as a outcome to see the outcome of growth velocity. However, in 2022, the Gothenburg model was validated, and we can see here there is a linear correlation between the observed and predicted height. So these prediction models will help us to counsel the parents regarding their growth velocity, and also it will help the physician to know which children should be excluded or avoided being treated with growth hormone because of its expense of the studies. So to finally conclude, this is the first prediction model generated based on the data from India, and prediction tools, they are accurate and they can predict the first year growth response in growth hormone deficiency children, and it will help us to counsel both patient and parents regarding the predicted height outcome and optimize growth hormone replacement therapy and contribute to the overall improved outcomes. Thank you.
Thank you, Doctor. Any questions from the audience?
To augment the effect of growth hormone. So, why there was less gain in height in peripubertal children compared to prepubertal children? You have shown that peripubertal children showed less growth.
Because
yes,
sir, because of the delay in the start of the growth hormone treatment, so that might be the cause why peripubertal.
No, it was first year gain in height.
Yes, sir.
So why there was less gain in height in peripubertal children? They might have under the influence of sex steroid too, and that is known to influence growth hormone action. But and so they are presumed to in the peripubertal children are presumed to have better gain in height rather than the prepubertal children. But you have shown that prepubertal gain more than the peripubertal.
So, logically, even though the sex steroids have potentiating effect on the growth hormone therapy, and so, but if we see the studies, those children which have started with the growth hormone treatment early in the prepubertal age group have the more chance of height.
That is your observation, okay, but I want to know
excuse me, we're running out of time. Can you just complete your answer?
Thank you very
Then we'll
much.
go on to
Have
the
you
next.
done a regression analysis about someone is having, say, 9 this peak GH or less than 5 or less than 7? Is the, as you have shown in pubertal?
Yes, sir.
Is there a minimum is less age is having better
all
response?
all the children were with growth hormone peak was less than 5 nanogram per ml, sir.
Okay. So then none
Less
of
than
them
10
are-
nanogram, sorry.
No,
Less
no.
than.
Is there any difference in the gross velocity if GH peak GH is less than 5 or less than 7? And
No,
like
sir,
that? Have you
that's
divided
not
in
it.
these 3 groups? Or no?
Nice, sir. No, sir.
Thank you.
Okay,
Thank you very
thank
much.
you.
Thank you.
Thank you. Let's proceed with the next presenter. Our next presenter is Dr. Nimisha Dange, who will be presenting on the comparison of the double burden of malnutrition in under 5 children using extended CIAF WHO 2006 growth standard versus 2019 Indian growth reference.
Good morning. I'm Dr. Nimisha Dange from Pune, India. Today I will be presenting a study titled Comparison of Double Burden of Malnutrition in Under 5 Children Using Extended CIF on WHO Growth Standards versus Indian Growth References. I will be discussing a novel concept to assess growth failure. Prevalence of double burden of malnutrition is quoted as high 55.8% using Indian DHS data. In under 5 Indian children, which is the highest among the South Asian region. Therefore, characterization of malnutrition using appropriate growth chart to include both under and overnutrition is critical. However, WHO growth standards have been reported to be a misfit in judging growth in under 5 children globally, and hence various countries have implemented local growth references. To implement national health policies directed towards malnutrition, CIAF has been proposed over traditional indicators. Composite index of anthropometric failure, I will repeat, composite index of anthropometric failure was originally devised by Nandi and Svedberg to include categories A to F and Y depending on stunting, wasting, and underweight. This concept was further extended by Kuiti and Bose by an additional line of overweight deflection to add additional categories group G and group H, stunting and overweight, and only overweight children respectively. Previously, in 2019, our group has published Indian growth references for 0 to 18-year-old children for over anthropometric records of around 46,000 children from North, South, East, West, and Central Zone of India belonging to middle and upper middle socio-economic classes. In this paper, we have compared Team Cole's LMS method and synthetic references to compare height percentiles, weight percentiles, and BMI percentiles. Due to the increasing double burden of malnutrition reported from India, it is necessary to use appropriate growth references. The nutritional status of exclusively breastfed under 5 children is important in defining DBM. The wealth index may be used as a proxy to account for socio-economic status. Taken together, the objectives of the current study are to assess double burden of malnutrition in under 5 Indian children using extended CIF on WHO growth standards and Indian growth references, to study prevalence of DBM in predominantly breastfed subgroup and according to wealth index categories. This was the secondary analysis on NFHS 5 data. Standard deviation scores were calculated using WHO growth standards and Indian growth references LMS method. Complete anthropometric records for children between 0 to 59 months were included, and those at the extremes of weight for height, weight for age, and height for age were excluded. The final analysis was performed over 196,000 anthropometric records. WHO standards significantly underestimated the traditional indices like weight for height, height for age, and weight for age in comparison with Indian growth references. The prevalence of normal children in the category A was underestimated on WHO charts, while prevalence of under failure as well as over failure was overestimated on WHO standards in comparison with Indian references. The distribution of children in each category of extended CIF was significantly different on both the charts as per the McNemo's test. When assessed separately, males and females had significantly different distribution using both the charts for extended CIF. Across all age groups, WHO growth standards overestimated the prevalence of extended CIF. Category F included only stunted children, which is included in the definition of under failure. Category G included stunted with overweight, which is included in the definition of over failure. 4% children on WHO standards and 2.5% children on Indian references, therefore, found to be in the potential overlap of the definition of under failure and over failure. 31% normal children on Indian growth references were under failure on WHO standards. 5% undernourished children on Indian references were stunted on WHO. 11% overnourished children on Indian growth references were normal on WHO, while around 55% majority of overnourished children on Indian references were short normal or short obese on WHO. These short normal children were around 6.8% on WHO. The prevalence of normal children as well as under failure and over failure was similar in the predominantly breastfed subgroup as that of the overall prevalence using both the charts. The prevalence of normal children on WHO growth standards was seen to be consistently decreasing after the second year of life, while there was a dip in the prevalence of normal children on the Indian growth references. This effect could be attributable to the shift of children from exclusive breastfeeding to weaning practices after first year of life, and this was complemented by a rise in the prevalence of underweight during second year of life, which was subsequently decreasing in the coming years of life. This implies that Indian growth references represent true nutritional status in the breastfed subgroup. According to wealth index categories, the prevalence of under failure was decreasing while prevalence of over failure was increasing on WHO growth standards. The prevalence of both under failure as well as over failure was higher in children belonging to poor households on Indian growth references. We explored the novel concept of extended CIF, and NFHS 5 data was analyzed, which is representative of the under 5 Indian children population. However, maternal nutrition and education needs to be assessed for double burden of malnutrition, and we require more longitudinal studies to understand the pattern of double burden of malnutrition over decades. To conclude, Indian growth references in comparison with WHO standards provide a realistic picture of double burden of malnutrition, which prevents further misclassification as either undernourished or overnourished. In comparison to WHO standards, Indian references represent true nutritional status in breastfed subgroup. In the context of impoverishment, Indian growth references show a higher prevalence of DBM when compared against WHO. Thank you.
Thank you, Doctor. That you have done the comparison both for under and over nutrition, because that's what is required from the charts and that's the need of the hour. And the best part is the WHO charts are very different from our Indian charts because they are the standard and their 50th percentile at the time of birth is 3.2 kg. And imagine our cohort as per NNF data is 2.750. So anyways, our cohort starts at a lower level. So therefore you will get these deviations. So our Indian growth charts are important, and WHO are just the standard charts which we are following. So that right from baseline, this difference is there. So that is what I wanted to clarify. Thank you.
Thank you. Yes, Doctor.
Thank you. Wonderful analysis. NFHS 5 is predominantly tilted toward female in case of adults. 80% of NFHS 5 is adult female. Just wanted to know male-female distribution in pediatric age group. It's also tilted toward female, or it's a normal distribution for Indian population?
I have analyzed data on under 5 children, 0 to 59 months. And if I could show my slides once again for the distribution.
Just give that information. That's all. Just wanted
it is
to know.
it is not tilted to either
Okay,
of the gender. The distribution is almost equal.
Because we have worked on adult population, not this age group.
Yes.
So this was 70 to 80% females, predominantly females.
Yeah. As the
Thank
data is humongous, I don't precisely remember the numbers, but I could show you through my slides.
Just ratio almost equal.
Almost equal.
Thank you.
Thank you.
Thank you. So now we'll move on to the next presentation by Dr. Nupur Wagasia, Reninoma, an unusual cause of growth failure.
Good morning, respectable seniors and friends. Unlike the previous studies, this is a case report of an unusual cause of growth failure. So, an 11-year-old girl presented to us with complaint of poor height gain over 1 year, along with complaint of continuous headache and occasional episodes of vomiting for the same duration. The headache was dull aching, diffuse, non-localizing, almost continuous, and only partly responsive to NSAIDs. There were very occasional episodes of vomiting, which, as per the description seemed by the parents, seemed to be non-projectile. Parents noticed that other girls of her age were outgrowing her in the height, and that was their main concern. There was no visual complaints, seizures, motor deficits, no history of any head injury or CNS infections, no history suggestive of hypothyroidism, rickets, renal disease, or any malabsorption. She was born of non-consanguineous marriage, was full-term, cephalic presentation, birth weight of 2.9 kgs. Her antenatal, perinatal, and developmental history was non-significant. There were no history of any childhood illnesses, and family history was non-contributory. Coming to the examination, her height was 135.5 centimeter and weight was 29.2 kgs. Although her height was within 2 standard deviation of mean for age, a review of her previous height records showed that she had always been on the 25th centile line. However, when she presented to us, the past 6 months had shown nearly no gain in the height, and this was accompanied by concomitant failure to gain in any weight. Her blood pressure was very high, 170 by 110 millimeters of mercury in the upper limb and 180 by 130 in the lower limb. Pulse rate was normal with no radioradial or radiofemoral delay, no pallor, edema, or icterus. There were no dysmorphic features or any syndromic features and no bony deformities. Her systemic examination was unremarkable and she was prepubertal. Coming to the lab evaluation, she had a normal blood count, liver function test, creatinine, urine routine microscopy. However, her venous blood gas analysis showed severe metabolic alkalosis. pH was 7.49, bicarb value was 29.5 millimoles per liter, and potassium was 2.9. She was euthyroid and her morning cortisol value was normal. Serum IGF-1 was low with a value of 63.5 nanogram per ml, and she had 46XX karyotype. For further evaluation for secondary causes of hypertension, aldosterone renin levels were tested. The direct renin concentration was found to be very high with a value of 858 microIUs per ml, and thus consequent serum aldosterone level of 36 nanogram per dl. She was started on treatment with amlodipine 5 milligram once daily, which resulted in normalization of blood pressure within 5 days, and she was given oral potassium supplementation. For further testing, a 2D echo was done which showed concentric left ventricular hypertrophy. Her bilateral renal arterial Doppler was normal. However, the renal ultrasound showed a well-defined homogeneously echogenic area in the upper pole of right kidney of size 1.3 centimeters. So, to further investigate, a CECT abdomen was done, which showed a 1.6 by 1.7 centimeter nodule in the upper pole of cortex of the right kidney with mild heterogeneous enhancement on the delayed phase. As the previous review of literature had shown poor specificity for the scanning in diagnosis of reninoma, we decided to proceed with a renal venous sampling for renin. We performed it on the protocol laid down by Wally et al. In 2015. So we found that the lateralization ratio was 1.74 to the right side. So for a cutoff of 1.5, the previous studies had shown a sensitivity of 56%, a specificity of 94% for correct lateralization. Thus, with the diagnosis of a right-sided reninoma, we proceeded with the surgery and a right open partial nephrectomy was done to remove the mass. The histopathological analysis of the removed specimen confirmed the diagnosis of reninoma with sheets of polygonal cells, well-defined borders, round uniform nuclei, and diffuse CD34 positivity. In the immediate post-operative period, her blood pressure normalized without the requirement for any hypertensives. Her headaches disappeared. And on post-operative day 3, the renin concentration was repeated, which fell from the value of 858 to 10.9 micro-IU per ml. Further follow-up at 6 months showed that her serum IGF-1 value improved from 63 at baseline to 179 nanogram per ml at the end of 6 months, and the same was reflected in the further height data. Over next 1 to 2 years, she showed a remarkable catch-up growth and regained her original height percentile. And over another 2 to 2.5 years of follow-up, she had almost achieved her target height in terms of mid-parental height. She had a spontaneous pubertal onset, menarche at the age of 14 years, and she continues to remain normotensive. Coming to discussion. In younger children, secondary causes of hypertension account for more than half of the cases, and thus these should always be investigated. Reninomas are functional tumors arising from modified smooth muscles of afferent arteriole of juxtaglomerular apparatus, and only about 200 case reports have been described so far across all the ages, with a female to male ratio of 2:1. Reninoma resulting in growth failure has not been described previously, likely due to the rarity of pediatric reninoma cases. The possible mechanisms that we could ascertain were, in the previous studies of children with Bartter syndrome who have hyperaldosteronism and resultant hypokalemic alkalosis, growth failure was concluded to be due to electrolyte disturbance and poor feeding, resulting in the impaired growth hormone secretion. Experimental studies on rats have shown potassium depletion was associated with reduced growth hormone response to the GH releasing factor, with resultant fall in the IGF-1 levels. However, only hypokalemia cannot explain the growth failure, as achieving normokalemia in Bartter syndrome children, however, did not restore the growth. Other mechanisms that we could suggest are that chronic systemic hypertension can damage the endothelial lining and cause release of certain inflammatory cytokines, which cause relative GH deficiency, impairment of IGF binding proteins, downregulation of GH-IGF-1 receptors, and also impair the local GH and IGF-1 signaling pathways. So the take-home points from this case is that height deceleration rather than just an absolute value of height is an important indicator of underlying systemic illness. Wherever possible, the previous height records should always be compared. Growth hormone IGF-1 levels and action may be affected by many systemic illnesses, and many of which yet remain to be described. Removal of reninoma led to a rapid regain of height percentile in our case. Thus, evaluation for secondary causes and their appropriate treatment and timely management are important to achieve good height prognosis. Thank you.
Thank you, Doctor. Any questions?
If nobody is asking, then can I ask? Yeah. So not part of your, it's wonderfully worked up case, not part of your workup of reninoma. Did you check suppression of aldosterone in these cases, saline suppression, which is seen in low renin hypertension? So you could have got more insight whether this aldosterone levels are suppressible or not.
No, sir, we didn't.
And could you check aldosterone level in your venous sampling? You checked DRC?
Sir, we just checked the renin concentration.
And not aldosterone.
No.
That could have given more information in unilateral production renin. Is there an increase in aldosterone level or not? but not required for your case.
Any other questions?
I think there's no more question. Thank you, Doctor. Let's proceed with the last presentation. So the last presentation will be optimizing growth hormone deficiency diagnosis in overweight obese children, a lower peak growth hormone cutoff for the insulin tolerance test, to be presented to us by Dr. Natakarn Numriskulkrat. I hope that I pronounce it.
Yes, thank you for your kind introduction. I'd like to begin my presentation by stating that I have no conflict of interest regarding this presentation. Okay. Well, we have known that obese children have lower basal and stimulated growth hormone levels compared to normal weight children. This is because obese child have higher leptin and free fatty acids, reduced ghrelin levels, that lead to increased somatostatin activity, suppression of growth hormone releasing hormone, and eventually it leads to decreased growth hormone production and secretion. However, the current diagnostic cutoff of growth hormone less than 7 nanogram per ml for diagnosis of growth hormone deficiency, which is currently used in many centers around the world, including our institute, does not account for BMI or obesity status. And this may result in overdiagnosis of growth hormone deficiency in obese children. To address this, we try to investigate whether a lower peak growth hormone cutoff from the insulin tolerance test or ITT can improve the accuracy in diagnosis of GHD in overweight or obese children. We retrospectively study the children under age of 18 with short stature or having growth failure who underwent the ITT for growth hormone deficiency evaluation at our hospital during 2018 to 2024. And we exclude the patient who has some systemic illness to suppress growth hormone secretion, the patients with prior growth hormone treatment, and the patients with incomplete medical record. We collect data including demographics, anthropometries, IGF-1, IGF-BP3 levels, the bone age, ITT profile, and the final diagnosis. And we categorize the subject into two groups. The first one is the GHD and non-GHD group. We categorize by using the standard diagnostic criteria from Thai Society Pediatric Endocrinology. And in each group, we further divided them into the overweight or obese and non-overweight or obese group using the BMI criteria from the World Health Organization. Our institute used the standard ITT protocol. After fasting for 8 hours, we collect baseline blood sample, including glucose, growth hormone, cortisol, ACTH level. And after the insulin was injected, we serial measure the growth hormone, cortisol, and the glucose at each time point. And our institute used the chemiluminescent immunometric assay for growth hormone analysis. Our data follow normal distribution, and we use the following statistical method for the analysis. Out of 116 subjects, 52 have growth hormone deficiency, and in this group, 10 were overweight or obese, while the non-GHD group, only 3 has non-overweight or obese, and the mean age is around 9.6 years, and 62.9% were male. Next, let's see deeper in the GHD group. We found no significant differences between the bone age, height, IGF-1, IGF-BP3 standard deviation score between overweight or obese and the other group. But we found significantly less delay bone age in overweight or obese child with GHD, and also higher bone age to chronological age ratio and the bone age advancement in the overweight or obese GHD compared to the other group. And significantly, we found that the baseline growth hormone and the peak growth hormone from ITT in overweight or obese children is significantly lower than the non-overweight or obese GHD children. For non-GHD group, we found that the peak growth hormone from the ITT in overweight or obese children is lower than non-overweight or obese children, but the baseline were comparable. This is the ITT profile. I think it's quite the same in every ITT test. The peak, the nadir of the blood glucose occur at 15 to 30 minutes after the insulin injection, and the growth hormone is peak at around 15 minutes to 30 minutes after the test. Okay, when we consider the sense aspect of different peak cutoff for diagnosis of growth hormone deficiency, using the current cutoff of less than 7 nanogram per ml from all participants is used the sense aspect at around 96 and 70%. But if we consider in the overweight or obese group, the specificity is only like 66%. And if we consider using like maybe lower one, around 6 nanogram per ml, is used sense aspect at around 100%. And even lower at 4 is used the sense aspect at 90 and 100%. Interestingly, we found no significant correlation between the peak growth hormone from the ITT and the chronological age, bone age, IGF-1 SDS, and IGF-BP3 standard deviation score. However, we found significantly negative correlation with the between the peak growth hormone from the ITT and the BMI standard deviation score, as you can see from the figure number 2. So let's go to the discussion. We found significantly less delay bone age in overweight or obese children with GHD compared to the non-overweight or obese one. This highlights the importance of like careful interpretation of the bone age, that the overweight or obese child with GHD may not exhibit like such delay in the bone age compared to the other. And BMI itself influences the peak growth hormone levels in both GHD and non-GHD subjects with overweight or obese. And previous study and current research, our research confirmed a negative correlation between the peak growth hormone and BMI, suggesting that higher BMI can lead to growth hormone deficiency over diagnosis. This study proposed a lower peak growth hormone cutoff of less than 6 for overweight or obese children to improve the diagnostic accuracy and reduce overdiagnosis. However, I think we have to be mindful because the optimal peak growth hormone cutoff for diagnosis of growth hormone deficiency may vary across countries and may vary depends on the pre-test likelihood of having growth hormone deficiency or clinical probability of each case, and also varies depend on the assay that used for growth hormone analysis. Our study also have the limitation, including the retrospective data collection and the small sample size, especially in the overweight and obese children. To conclusion, a lower peak growth hormone cutoff of less than 6 should be considered for diagnosis of growth hormone deficiency in this group of patients, maybe to reduce the overdiagnosis and avoid unnecessary treatment. Thank you so much.
Thank you, doctor. Question?
Actually, it is not my question. It is my own personal experience to a case. I have an obese child, and on growth hormone estimation in all his samples, growth hormone was below 1, and the child grew normally as an adult. So BMI can have profound impact on growth hormone level. So it should be kept in mind.
Yeah, thank you so much for your comment.
The small, just I want to ask that we are talking in terms of 6.
Can we have?
Kept in mind before doing growth hormone estimation test. If the child is growing within mid-parental height and obese, there is no need of doing growth hormone estimation. It will invariably be low.
Thank you for that comment, doctor. Can we have the question?
Yeah, the question is that, if you are having the patient, an obese patient, most of these obese patients will be stunted also, right? So that means you're talking GHD, it will be stunted with along with the, bone age will be slightly more than normal for any other child of that same age who is non-obese. Okay, now what I'm trying to say that if we take a cutoff of 6 and we are maybe diagnosing more patients of GHD with obesity. Overdiagnosis, na? Because if I take cutoff 7 or if I take cutoff 8, it'll be easy. That means I will not be diagnosing the over cases of obesity. But if I take cutoff 6, I will be over-diagnosing cases of obesity. I'm making more GHD with obesity, which is actually going in the opposite direction. I should be making less cases of GHD with obesity because I know the other obesity causes, behavior causes changes in these factors. You understand what I'm trying to say?
I'm not quite sure that I
Rajesh, just
understand
try
you
to-
correctly or not. You mean that if we adjust the cutoff, we may result in
Over-diagnosing, over-treating many more patients because 6 is a lower level as compared to 7. So when you're taking GHD into consideration of 6 as a cutoff, you will be treating more patients, which actually may not be actually with GHD.
From my point of view, maybe, for example, if we cut, if the child maybe me 6.5 nanogram per ml, and we use the previous cutoff of 7, I might consider having GHD. But if we lower the cut point to 6,
That is why when we treat obese children with the GHD, we always do it surface area. We never treat them on the basis of weight. So this
right.
Suggestion. So validate in more larger samples.
Yes.
Suggestion is very valid. You said there are many confounding
factors. Got it.
There are many confounding factor who is making GH low, and now you have make the cutoff again low, so you'll be over diagnosis.
Did you excluded genetic or some causes of obesity?
Yes, we exclude the patient with, for example, Prader-Willi syndrome. We already exclude that.
Okay.
Yeah. Do you have any suggestion? I want to hear from you.
Yeah, these cases have to be excluded for such a study.
Okay.
Yes,
So
thank you.
thank you very much. This wraps up our session. Thank you for attending this conference.
Thank you, chairpersons, and thank you, speakers, for the wonderful presentations. I request Professor Vandana Jain, ma'am, to come forward for facilitating our chairpersons. Thank you. Thank you very much.